Great.
for all that. So.
Okay.
Perfect. So it is 10 o'clock. Do you all want to wait a little bit before we get started? Welcome, everyone. Thank you for joining us. We'll get started in just a couple of minutes. I know people run on different times. We're polychronic sometimes in our time orientation. So, but it's nice to see folks this Friday. And again, super excited to have Dr. Thompson join us this morning at our first Pluralism, Inclusion, and Equity series of 2024. So welcome. I just got a message from somebody who said that the link wasn't working. So let me try sending it again. It worked for some of you. You're here.
You use the copy the invitation instead of copy the link, it gives the password and everything, whereas the link just only gives the hyperlink. But do the copy invitation, it should go through with a password if they need it.
Thank you. Was there a password needed?
No, but sometimes you'll have, as Dr. Thompson was saying, you'll find the glitch, and that's one of those for that.
Yeah.
So if they need the password to have that with the copy invitation, it'd be link
Oh, I
included.
see. Definitely. Thank you.
I think Lenore on the flyer, the Zoom link is correct, but the one sent through Advantage is a different one. And tried to go through that one and it wouldn't work and it said bad request, but the one on the flyer is good.
Okay. Maybe if Danielle, is there a way that you can check the Advantage and update it?
I can reach out to Joseph to see if he can do that real fast.
Thank you so much.
Of course.
Perfect. So I see in the chat that some folks have to leave. So how about we go ahead and get started, and then folks can join us as we go. So welcome, everyone. I'm Dr. Leonor Cadena, and I'm a faculty member at Fullerton College Anthropology Department and co-coordinator also of the department. And I also have the honor of collaborating with the Office of Diversity, Culture, and Inclusion, and I've been part of it for 8 years now. It's been a long time. And on behalf of this office, we would like to welcome you to our first Pluralism, Inclusion, and Equity series of 2024. And the series is meant to bring leader experts addressing topics relevant to diversity, equity, inclusion, accessibility, and anti-racism. We created these workshops and trainings with the goal of increasing our intercultural proficiency and relevancy to uniquely issues or aspects that affect both our student population as well as our community, our staff, our faculty, and the whole community basically that we serve. And of course, our speaker today is also invited to help us celebrate and honor Black History Month. But before we begin, let me go ahead and have our team introduce themselves. I'm going to go ahead and start by asking our Director of Diversity, Culture, and Inclusion to start introducing himself.
Thank you so much, Dr. Cadena. Hello, everyone. My name is Flavio Medina Martin. I am the Director of Diversity, Culture, and Inclusion for North Orange County Community College. Glad to be here, and I'm excited to hear Dr. Thompson's presentation. Thank you so much. Professor Banda, I'll send it on over to you.
Thank you. Good morning, everybody. Likewise, I'm very, very excited to be here. And my name is Sergio Banda. I'm in the Sociology Department at Fullerton College. I'm also one of the faculty fellows representing Fullerton College. Welcome, everybody. And I'll go ahead and pass it along to Dr. Letcher.
Good morning, everyone. Thanks for coming and participating on your Friday, especially a Friday where it is not raining. All right, I am Annette Letcher. I'm an English professor at Cypress College, and I represent the faculty fellows for the district at Cypress College. Thank you again for coming, and I'll pass it over to Virgil.
And good morning, everyone, and good to see those who we have on camera and those who are not. We welcome you, and our esteemed keynote speaker, Dr. Thompson. I am working at the Office of Diversity, Equity, and Inclusion, Anti-Racism and Accessibility. It's a long name, and I want to thank you all for spending this time with us. We look forward to a wonderful, enlightening discussion. So join in.
Thank you. And I see that our chancellor is joining us this morning. Dr. Brilliant, would you like to say a few words? I don't know if you're able to. We're just doing introductions.
Yeah, just good morning, everybody. Yeah, thank you for acknowledging me. I just came by to pop in. I'm unable to turn on my camera at the moment, but I know we're going to have a great session. Thanks everybody for joining, and thank you all for planning this event as well. Appreciate it.
Thank you for joining us.
Leonor, you're muted.
Oh, thank you. We're just talking about how we have to make t-shirts, right? You're muted. It's a common theme. Sorry. Just a few housekeeping reminders. And again, thank you, Dr. Vreeland, for being here. And the reminders would be to make sure you mute yourself if you're not the one speaking. Also, we know it's hard sometimes being remote. If you get disconnected, just join us back. We'll be here. If you have questions, please wait at the end of the presentation. Dr. Thompson will allocate some time for Q&A. And finally, if you did not hear this at the beginning, we are recording the session as part of our archives. So we'll go ahead and get started. Please join me as we welcome today's speaker, who does not need an introduction. She's a leading scholar who demonstrates the excellence of inclusivity and equity in the fields of genetics and medicine. Dr. Alexis Thompson is chief of the Division of Hematology at Children's Hospital of Philadelphia. She holds the Elias Schwartz, MD, Endowed Chair in Hematology. She's a graduate of Tulane University School of Medicine, where she will soon be invested in their Hall of Fame. She also earned a master's in public health from UCLA. She has received so many awards. Most recently, in 2023, she received the award for leadership in promoting diversity by the American Society of Hematology. She appears in numerous documentaries, including one which I showed my students titled The Gene as a PBS documentary. And again, she has so many awards and so many publications that I figured we'll take the whole time if I read them all, but I do invite you to check out her work. I have to also mention she was in Good Morning America just last week, being recognized for her efforts during the Black History Month. In this series, Dr. Thompson will share the importance of sickle cell research and breakthrough in medicine, technologies, and efforts in developing a cure, as well as the benefits of diversity in medical research. So I'm going to go ahead and hand it off to Dr. Thompson. Please join me as we welcome her.
Dr. Cadena, thanks so much for the very, very kind introduction. I'm going to share my screen, and I'm going to keep my fingers crossed that I can make this work after how many years in this cone. Let's see. Are you able to see my screen? How are we doing? Are you able to see my screen?
Yes.
And you can see it.
So this is a really unique opportunity for me to kind of blend two things that are so important that I think sometimes there's an assumption that these perhaps are not linked, and really, frankly, nothing could be farther from the truth. And one of the areas that I have a particular interest in is sickle cell disease, which I'll describe in detail for those who may not be familiar with it. But really being able to use an equity lens to look at the progress that we've made toward a cure for sickle cell, and really where our opportunities are to continue to make progress. These are my disclosures. I'm not going to be talking about anything that's relevant in terms of off-labeled indications for any medications. What I hope to cover today is really looking at scientific racism, really as a distinct form of structural racism, something that certainly has been very much a part of my career arc. Sickle cell is a study for the complexities of race and science. The DEI lens and the interrelationship of publishing and research, and then opportunities for moving forward. I want to also frame it in terms of looking at it symbolically. And so this is a Khan symbol called Sankofa, which means essentially go back and get it. So it's a symbol of a bird plucking an egg off of its back. And the importance of Sankofa is what it means is the importance of reaching back to knowledge gained in the past and bringing it into the present in order to make positive progress. It's also important as we think about framing this to recognize that when we talk about structural racism and systemic inequities, that many of us come from different perspectives. And so while more often than not, I often think about racism or inequities as they relate to health disparities and the issues that are confronting my patients and the communities in which they live in, I have to constantly remind myself that many times that the real world and real lived experience of all of us, but in particular with my patients and their families, is the fact that we are actually, that they and we are part of a system, including our employment system, criminal justice system, media, education, and housing, all of which individuals encounter all of the time. And so that there are strings attached to all of us, strings attached to me, to my patients, to our systems, and therefore that there are sources of systemic inequities and structural racism that can come into play in a variety of ways that may have negative consequences for those who are at highest risk. When I talk about scientific racism, I dare say it began far, far, far before we had anything that we call structural racism or systemic inequities. They begin with this false belief of biologic Black inferiority. And in many ways, these were initially offered by, for instance, the Portuguese in written literature as an attempt to justify slavery. But in the 1700s, certainly one of our founding fathers opined that in imagination, they are dull and tasteless. This unfortunate difference of color and perhaps of faculties is an absolute obstacle to emancipation of these people. Moving into the 1800s, we continue to see evidence of scientific racism, starting with Dr. Samuel Wright, who was an appointed professor at my alma mater, and he was considered a professor of the diseases of the Negro. And he coined this term, drapetomania, a disease that caused enslaved Blacks to attempt to flee due to their smaller brains and blood vessels. And that he went on to postulate a variety of differences, largely that he perceived, not necessarily proven, but that suggesting that that these changes were pervasive and that they had a biological connection, which we know is completely false. Later in the 1800s, we see Dr. Thomas Hamilton, who tried to prove that Black skin was thicker. And a lot of those experiments were done on the individual who was on the previous slide, John Brown, inflicting torture on John Brown by applying a variety of agents that cause blistering of the skin. But probably one of the most profound examples is Dr. J. Marion Sims, who even today is considered the father of modern gynecology, largely because of the many techniques and, in fact, instruments that very much look like the instruments that are currently used in gynecologic care that are attributed to him. Yet Dr. Sims performed these gynecologic surgical procedures on enslaved Black women without their consent and all without anesthesia. And this was based on his misguided belief that Black people didn't experience pain like white people. He, of course, went on to use these refined techniques on white women under anesthesia. Health disparities, as we understand it today, is a particular type of health difference, and it is linked to social, economic, and environmental disadvantage. Health disparities adversely affect people of color because these are things that they systematically experience, and they are greater obstacles to health based on race, ethnicity, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disabilities, sexual orientation, gender, identity, geographic location, and other characteristics which are historically linked to discrimination or exclusion. And so while we looked at these what we seem to be fairly remote instances of scientific racism there clearly is a linkage forward into what we now call health disparities. And suffice it to say, even with as much knowledge as we have obtained in the last 2 centuries, it's safe to say that we clearly have not overcome many of the things that contribute to ongoing health disparities. When we think about the DEI lens, it often falls into 2 important differences: implicit versus explicit bias. And this is important because I think when we think about explicit bias, we're talking about a prejudice or a stereotype that the individual who has this is aware of. And so this is done with intent. As opposed to implicit bias, where arguably this can be a prejudice or a stereotype that is unconsciously held. Intent is not what's so important. What is most important is that both implicit and explicit intent affect our actions and can cause harm to others. And I'll give you a few examples of that generally, and then we're gonna start targeting in on sickle cell, an area that I have a specific interest in. One is when we think about inadequate pain control. There continues. So this is an article in the Proceedings of the National Academy of Science, a prestigious scientific journal, just from 2016, less than 10 years ago, where we continue to see evidence of a perception that Black patients have higher pain thresholds. There are substantial numbers of white lay people, medical students, trainees, which we call residents, who hold beliefs that Blacks have higher pain thresholds even now. And that because they hold those false beliefs, they are more likely to offer inadequate pain control to patients in simulated scenarios. There also continues to be the perception that among those same individuals that many times that the requests and the need for pain control reflects drug-seeking behavior, and that there's an element of blaming the patient for their pain and not believing reported scores, even though in many instances, and I certainly will show you one, as sickle cell disease, pain can be a symptom of the disease itself that has clear physiologic explanations. There are also examples of the consequences of this bias, and these are examples that, again, that are fairly recent, and these are in the field of pediatrics. Sadly, these are my colleagues, many of whom these are multi-center studies that have been done at some of our finest institutions in the United States, showing differences in how we would treat a child who presents with a fracture. That a child of color is less likely to be given a narcotic for pain with a documented fracture compared to a white child, and that the length of time that it takes for them to get pain relief is far longer. Similarly, a child of color presenting with abdominal pain and having an appendicitis is also less likely to receive the same pain relief or the same medications for pain control that another white child would have. And so whether you call this implicit or explicit bias, these are clearly consequences that cause harm and harm to children. What is sickle cell disease? Sickle cell is, again, is something that I see day in, day out, but perhaps for some in the audience who may not be as familiar with it, it is the most common inherited blood disorder in the United States. It's due to a genetic mutation in a gene called beta globin, and beta globin encodes a key component of human hemoglobin, which is that substance that makes our red blood cells red because it's important for carrying oxygen. It's autosomal recessive, and so it requires that you inherit the trait from both parents, and affects, we think, about 100,000 Americans. In all 50 of the United States and the United States territories, we have newborn screening, which is mandatory and universal. And we have shown over time that doing newborn screening, which takes place at the hospital when a baby is born, reduces morbidity as well as mortality to sickle cell disease. We know that 1 in 365 babies born in the United States will have sickle cell disease. What's often overlooked, however, is that 1 in 10 new babies with sickle cell disease is Hispanic. And so that if we only go by what we are some very high level appearances in terms of whether we perceive it as a Black child, we will be overlooking the possibility of taking care of a child in need. When you have sickle cell disease, it's a severe hemolytic anemia. So anemia that's caused by fragmentation of red blood cells. That can have acute complications. It can be life-threatening, but also chronic damage to organs that can also lead to premature death. This is a really uncommon disease because there are acute manifestations that will require urgent care, but also chronic manifestations that require access to ongoing high-quality care. This disease was first described in 1910 in the Western literature. And over the time from 1910 to the 1980s, very little happened in the way of actual relevant improvements in terms of its impact on individuals. But starting in the 1980s, we began to see a number of interventions, starting with not only newborn screening, but also using penicillin to protect against life-threatening infections, and a number of medications that were being tested in clinical trials. And so across the spectrum, you'll see that there's a number of highlights in terms of accomplishments. But there have been major advances in the last decade, including gene therapy, which I'll spend a fair amount of time on today. These milestones have actually had some impact. So, for instance, through the 1970s and into the 1980s, one could argue this is primarily a pediatric disease. And so that it was largely something that pediatricians knew a lot about, but maybe adult doctors less so, because the life expectancy of individuals with sickle cell disease was often fairly low, with people dying in their 20s, before their 20th birthday, before they reached adulthood. A number of things occurred from the 1970s onward, including the beginning of screening, but also the National Sickle Cell Act, which occurred in the Nixon administration and called for not only testing, but also investment in research, beginning in using penicillin, a drug called hydroxyurea or hydroxycarbamide, and then a number of other measures so that we see that life expectancy curve going upward. And so certainly the increase in that trajectory was absolutely a good thing. Yet, when we think about disparities, this could not be more profound, so that while we have made progress, the improved life expectancy still lags behind the life expectancy of most Americans by nearly 3 decades. And so clearly, while we are making some progress, that gap still needs to be closed. It's particularly important when we think about the progress that we've made looking at African-American mortality, which is the dominant group in the United States that has sickle cell. Certainly, when we look at the mortality rates in children over time, we can see that it has gone down and certainly dropping since newborn screening has come into effect in the last 20 to 30 years. Yet when we look at the same for adults, we're still continuing to see the mortality rate among African Americans with sickle cell disease continuing to rise or plateau, but certainly not decreasing. That's particularly important when we look at dividing them up into various groups based on age and the crude mortality rate across time. And I call your attention to this group of people that are between the age of 20 and 50, people that we think should be in the prime of their lives, yet this is the peak mortality rate among patients with sickle cell disease. So they're dying clearly much earlier than any of us would like. And so certainly the opportunities to impact is urgent in that we're seeing people who are dying far too young. But the racialization of sickle cell began really at the very outset. So I mentioned that the first report of sickle cell occurred in the medical literature in 1910. This was very curious. Even in that very first definition of this disease, they described the anemia with these peculiar elongated cells, because that is what sickle cells look like when you look at them under a microscope. Yet, and it was seen in a dental student from the West Indies. And the authors felt the need to also not only talk about the anemia, but also to add their impressions about the intellect of the individual and their race, even from the very beginning, even though this was not a disease, this was a single individual with this, with no otherwise any framework for attaching anything about his intellect or his race. Sickle cell, the research in the advances in sickle cell were largely laboratory based, with understanding about the relationship of sickle cell to hemoglobin being defined in the late 1920s. And then Linus Pauling, the Nobel Prize winner, determined that the hemoglobin, that there was actually a change, an alteration in hemoglobin that defined sickle cell disease. And because this was at the molecular basis, sickle cell was and continues to be called the first molecular disease. And so while Linus Pauling, as a scientist, deservingly was given quite a bit of credit for this finding, Linus Pauling, as a human being and as an individual, I would argue is quite flawed, because Linus Pauling also suggested that the time might be here where we should actually be sure that individuals who are carriers for sickle cell and therefore have trait should actually have a tattoo applied to their forehead to make sure that young men and young women who are carriers do not mate. And this was not metaphorical or because Linus Pauling was actually asked about this many times. And at no point in time did he ever step away from his core belief that this was dangerous and that we should, and that this is certainly what he is advocating is essentially a form of eugenics, something that he didn't shy away from over his lifetime. So when I think about sickle cell as a study in disparities, it's a unique disease because it affects a historically overlooked, underserved, and underrepresented population. It's a disease that disproportionately compromises their quality of life, and because they suffer from multi-organ damage, it may be the primary cause of premature death. It also is a disparity because patients have inadequate access to healthcare services. I think it's also worth noting what patients say. So when patients come in with pain episodes, which is the signature finding in sickle cell disease, many of them continue to note inadequate pain control. So that is not in dispute at all at this point. And there's an undue extra burden on when patients do report that they have pain of being believed. And that I shared with you some earlier data, so that also is not surprising. I think what, though, is very troubling is when patients repeatedly tell you about needing to dress nicely when they come into the emergency room. So this is someone who is in enormous amounts of pain, yet they feel that they somehow must dress up for me and my colleagues to avoid being judged or worse, being mistreated. When we think about disparities in sickle cell, it's also worth noting some interesting data about disparities related to research. And so this is data that actually looks at comparing sickle cell to another inherited disorder called cystic fibrosis. This condition, there are 3 times more individuals with sickle cell disease, 90 to 100,000 in the United States, compared to those with cystic fibrosis. Yet there are 3 times less dollars that are delivered by the NIH for funding research in cystic fibrosis compared to sickle cell disease. We also know that there are over 10 times more private dollars spent on researching and funding research for cystic fibrosis compared to the funding from the private sector for sickle cell disease. There are fewer papers written about sickle cell disease compared to cystic fibrosis, and there are fewer drugs designed specifically or studied specifically for sickle cell disease. So today there are now 4 agents that are available, and most of those cystic hydroxyurea was identified in the late 90s. Then we went about 20 years with no new drugs for sickle cell. We now have had 3 that have been approved since 2017. When we think about complex, serious medical conditions, whether it's cancer or diabetes, or cystic fibrosis, or really any other conditions, the ability for us to have sufficient tools to make progress really are hampered if, in fact, new drugs are not being developed. There was a report that was actually commissioned by the Department of Health and Human Services in 2020 to ask the questions about how do we look at a strategic plan and a plan for action, specifically for sickle cell disease. And the Department of Health and Human Services charged the National Academies of Science, Engineering, and Medicine. They charged a 14-person committee to actually review over a 1 to 2 year period and to make recommendations. And this 500-page report could not be more comprehensive in terms of looking at a vision for a long, healthy, productive life for those living with sickle cell disease and also the carriers, those who have sickle cell trait. It's impossible for me to do justice to that, but they had strategies that went across 7 fundamental pillars, and each one looking at different ways that we can make an impact in sickle cell disease. But what was actually profound is what these individuals commented in the preamble at the very beginning of their report. And that was improving outcomes for sickle cell disease care requires comprehensive team-based care, new payment models, and addressing institutional racism in healthcare. And so we do have current treatment. So I've mentioned drug treatment. So we have some treatment, there are some benefits, but there are not enough of them. We have stem cell transplantation, and I'll discuss that one with you, which is a way of actually replacing the very cells that make blood cells as a way potentially to cure sickle cell. I'm going to touch on gene therapy as a future treatment, but the FDA preempted this slide because in December, they decided to make these commercially available. So it is now a current treatment. When we think about cures for sickle cell, stem cell transplants, bone marrow transplants, hematopoietic stem cell transplants, those are all the same thing, can be done. And they are usually done with a related matched donor. And that matched donor is usually a brother or sister. We now have some experimental approaches where we use unrelated donors that are part of things like the National Marrow Donor Registry in the United States or the Umbilical Cord Registry in the United States. And then we have some data on partial matched donor transplants, and then also gene therapies. And when we think about matched sibling transplants, this is looking at overall survival on one side. And here, looking at overall survival, which is quite high. Matter of fact, it's extraordinarily high when we use bone marrow or peripheral blood, or cord blood as a source of the stem cells themselves. We have high survival, and we have low risk of a complication called graft versus host disease, which can be a horrendous complication of transplant and can often lead to premature death. And so clearly at this point in time, we would consider a sibling donor transplant to be standard of care for sickle cell. What's most notable, though, is that most patients with sickle cell will lack a suitable matched donor or an unrelated donor. And that merely comes because of the simple proposition, and that is that most of us will not have a brother or sister who is sufficiently matched in what are called HLA antigens to be a match to do a safe transplant. And when we look at unrelated donor sources like the National Marrow Donor Program, many patients of color will also still not be able to find a match. And so that's where gene therapy comes in. What is gene therapy? Well, gene therapy is any experimental technique that uses genes to treat or prevent a disease. And what's most unique about gene therapy is the patient is their own donor. And so the barrier to effective curative therapy conceivably or theoretically goes away because we don't have to have a sibling who matches. We don't have to have an unrelated individual who volunteers to be part of a registry and happens to be a match. How does it take place? Currently, it is considered what's called ex vivo, and it's because we collect the patient's blood-forming cells, we take them out of the body and in the laboratory, so ex vivo, we modify those cells and then we reinfuse them. And we insert hopefully the normal copy of a single gene, or we modify another gene's function in order to have a benefit. In sickle cell disease, what we try to accomplish is actually having red blood cells that are not predominantly hemoglobin S, which is the sickle hemoglobin that's inside of the cells for anyone with sickle cell disease. but instead to have red blood cells following gene therapy where the predominant hemoglobin is some type of hemoglobin that cannot sickle. And so that's either, and so that's being achieved in a number of ways. But at the end of the day, we no longer see this ability of red blood cells to form this abnormal shape, which causes the pain and the organs damage that you would see with sickle cell disease. And so this is a therapeutic goal when we do gene therapy. We have two different approaches, and this is a bit of a wonky slide. Don't worry about all the different arrows and blah, blah, blahs on this slide, but this is important only because these are the two things that the FDA had just approved. One is called gene addition, where we use an inactivated viral vector and package in a normal copy of a human hemoglobin gene inside of an inactivated viral vector. And that vector, because it's a virus, infects a human cell, and then that DNA is transferred into the nucleus of that cell and then integrated into the patient's DNA. And so that integration makes that a permanent change in the person's DNA because it's retained in the stem cells that are repopulating their bone marrow over and over and over again. Gene editing is similar in that, it's done ex vivo in the laboratory, but instead what's applied is what we call molecular scissors. And so instead of a virus, we actually have those materials actually transferred into the patient's, the individual cells in the laboratory, where they make DNA cuts, which are called strand breaks. And then a change is made based on the sequence of a guide RNA. And then the body does its own repair mechanisms to either disrupt a gene or to repair a gene. What happens to the patient is that the patient actually has their stem cells mobilized. So they come out in the peripheral bloodstream just temporarily, and they're collected on a machine while the patient's awake for over 2 or 3 days. And then they're sent to the laboratory where their stem cells are selected, the new gene is introduced, and then they are frozen. Those frozen cells are then sent back to a hospital like mine, where the patient is given chemotherapy to make space in the bone marrow for these corrected stem cells. Their corrected stem cells are then infused into an IV, and because they're stem cells, they go to the marrow on their own. And then they remain hospitalized until we see evidence that those cells have been grafted and they start making healthy stem cells, because they now have gene therapy derived hemoglobin that they're capable of making. And then they are followed for a total of 15 years, both in research studies and in the commercial setting. How's it working? Well, it's working remarkably well, with 94% of individuals who have undergone gene therapy in the most recent iteration becoming pain-free. And so in this graphic, each one of these lanes is an individual patient. And each one of these diamonds is the time that they're hospitalized over that 2-year period for a pain episode. And so you can sort of see some of these individuals are in the hospital quite a bit for pain episodes. Yet after they undergo gene therapy at time 0 and then recover from their gene therapy after 6 months. And so they have complete resolution of their pain episodes in 32 of the 34 patients in this trial. When we think about gene editing, the gene editing approach uses something called CRISPR-Cas9, which has been a remarkable story of discovery only 10 or 12 years ago, and the Nobel Prize being awarded to 2 women in 2020, and this now being an approved drug. This actually targets a gene called BCL11A, so not the sickle hemoglobin gene, but instead one that actually is responsible for the maintenance of something called fetal hemoglobin, which is non-sickling, which protects babies who have sickle cell disease so that they actually get through pregnancy, are born, and actually are pain-free. And it's only when we turn on adult hemoglobin that they start having problems, because their adult hemoglobin is actually sickle hemoglobin. BCL11A is actually responsible for turning off fetal hemoglobin. So if I could turn off BCL11A, then the question is can I go back to making fetal hemoglobin? Because after all, it was non-sickling. And so that is the question that was asked about using CRISPR-Cas to modify BCL11A and to turn it off. And that's what was described in this clinical trial, where again, same principle, where we have individuals and all the times that they were admitted in the 2 years prior to gene therapy for pain episodes, the period of time right after they get gene therapy and they're still getting blood transfusions to support them, and then the period after that. And of those patients, 29 of the 31 patients, or again, remarkably, 94% of those patients were free of pain episodes that required hospitalizations after they underwent gene therapy. And so as a result of that, in December of 2023, the FDA approved exa-cel, which is the CRISPR gene therapy, as well as lovo-cel, which is the gene addition form of gene therapy for sickle cell disease. In both instances, it's been approved for anyone over the age of 12 who has a sickle cell diagnosis, primarily if they have pain, even though pain is not the only manifestation of sickle cell disease. And I think if you've been reading some of my favorite journals, like the New York Times, many of us are well aware of the price tags. $2.2 million for the Vertex version, $3.1 million for the Bluebird Bio version. So it begs the question in terms of access and equity. Once these drugs are approved, and now that they are, will the cost keep them out of reach for some? This is an important question that we have yet to answer. The first patient has not yet been treated in the commercial setting for sickle cell disease, but sickle cell and gene therapy is one of many high-cost therapies that are currently confronting governments, not only the federal government in the United States, but governments around the world for some of these multi-million-dollar therapies, a question that we will all need to wrestle with in order to address access and equity. We also need to democratize access to it in terms of information. And so this is an effort that's been undertaken by the National Human Genome Research Institute to democratize gene therapy by creating accessible, understandable, actionable, open source educational materials for patients and caregivers. So we're not dependent upon the story that might be spun by a pharmaceutical industry. You're not dependent upon something on social media or something that may or may not be vetted, but instead you can find sources of reliable information. You can download them, you can put them on your website because they're open source. But we're trying to find ways to actually look at opportunities using lay language that's been developed primarily by educators to be sure that individuals can educate themselves about what is gene therapy and to make decisions. When I talk about much of what I've talked about, I've largely talked about the American experience because most of these clinical trials and many of these medications currently are largely available in high resource places like the United States. I would be absolutely remiss, though, if we did not frame this in a global perspective, because in our current state, we expect the number of people with sickle cell disease to increase by 30%. So I talked about there are 100,000 Americans with sickle cell. There are millions of individuals with sickle cell disease globally. 75% of those individuals are in sub-Saharan Africa. 90% of those children in sub-Saharan Africa who have sickle cell disease will die before their 5th birthday. So that while we have between 1,000 and 1,200 babies born in the United States with sickle cell disease every year, there are over 1,000 babies born every day in Africa with this disease. And so our ability to actually see progress must include some solution that involves thinking about patients in the areas of the world with the highest burden. And that's depicted in this study, in this article, also in the New York Times, a Nigerian family who's already lost 3 daughters to sickle cell. And the question is can they save their 4th daughter? Will advances in sickle cell diagnosis, treatment, and I dare say cure, reach those in high burden countries? And so as we think about disparities in the US context, it's important to also think about our opportunities to think about the vast disparities that occur globally. Some of this is clearly the source of bias and racism. And so when we think about those things and the contribution that they are making to this, perspective matters. So depending upon how you are looking at it and what your point of view is, you may come away thinking about different things, and it's largely because of the perspective that you have. What can we do about it, no matter what our perspective is? First and foremost, when we think about bias and racism, we must recognize it. Once we recognize it, we must name it. Then we must oppose it. And then finally, we must replace it. When we think about recognizing it, it's important for us to start close to home. We need to check our own bias. As I mentioned, implicit bias is something that we may not be conscious of. And I dare say that many of my colleagues in the emergency room and elsewhere, really, I do not believe come into work every day intending to harm anyone. Yet, it's the bias that those individuals may have in terms of their beliefs or that there are a problem. And so not only should you check your own bias, you should check other people's bias as well. When we talk about naming it, we should avoid euphemisms. We should use clear terminology, and we should challenge those who deflect or deny bias and racism clearly that we see all around us, again, to avoid causing harm. This is an amazing example of that, also from the New York Times in 2021, an article that detailed the disturbing number of people who die in police custody, and it's being attributed to sickle cell trait, meaning it's because they are a carrier of this abnormal gene that somehow it's attributed to their death. Over a 25-year period, they found 47 cases where Black individuals who died in custody had sickle cell trait being the attribution by the medical examiner to their death, despite rarely apparent and often severe trauma. Nonetheless, the autopsy report and makes mention of a sickle cell crisis in someone who does not have sickle cell disease as a contributor and sometimes actually the true cause of their death. We must oppose it. And we must oppose it even in the highest places. And so while many of us think the American Medical Association certainly is the largest association of physicians in this country, having an editor espouse that it is impossible for a physician to be racist. And so therefore, how can there be structural racism in healthcare? Could not be more absurd. And so certainly there were much outcry at the true blindness of a major medical journal to racism as a healthcare crisis. And also finally, seeing things like I saw on the previous slide with the number of individuals dying in police custody, and there somehow being some medical or scientific merit to this has to be strongly opposed. And this is from the American Society of Hematology, strongly pointing out this is our area of interest. If it is not possible for individuals with sickle cell trait, especially under any circumstances, to be the proximal cause of death. And so that we as hematologists absolutely deplore any medical examiner who will use sickle cell trait as a cause or a major contributor to death for Black people while in police custody. When we talk about replacing it, some of it has to do with who is actually in the room. And this, I want to turn to our opportunities as in the academic space to think about our leaky pipeline in terms of academic leadership. When I look at medical education, my area, we start out with about 1 in 5 individuals who are members of an underrepresented in medicine group in applying for medical school. Slightly smaller number currently matriculating within medical school. And as they go through the pipeline of residency, which is the training after medical school, into faculty, the numbers that are underrepresented continues to drop. When we think about the arc from a beginning of a faculty person, say as an instructor or as an assistant professor, becoming a full professor, and then leading a medical school as a dean, the numbers continue to fall. So what are the factors that contribute to disparity in promotion for individuals from underrepresented groups in medicine across the academic spectrum or the academic continuum? Well, the NIH actually has done some introspection on this one. So this is data from the NIH itself. It could only be done by the NIH that looks at the likelihood of actually being granted an R01, which for many of you in academics may be well aware that the R01 is actually the gold standard for the excellency of a research proposal, and that anyone in academic medicine who does research must have one or more R01 awards to fund their research. Yet the probability of getting an R01 by race or ethnicity is starkly different. And so when we look at either whether you are, in particular, I think the one that's clearly is most striking, looking at, say, people of African ancestry, that they have a significantly lower likelihood of actually having NIH funding through the R01 mechanism. We think that about 20% of that may be related to their choice of research areas, which I'll touch on in just a minute. But certainly the fact that you actually are not actually, the likelihood of you're receiving that kind of award certainly is going to put you at a disadvantage. Publications as a predictor for NIH funding is also profound. And so whether you are a new or an experienced Black scholar, you are likely to have fewer publications, are likely to have fewer citations, are less likely to be a co-author, and that you are less likely to have your work published in a high impact journal, which is another metric that we use in academic medicine. So whether you are new or experienced, it does not seem to improve. We also know that you're undervalued and undercited when it comes to actually when you do have papers. And so whether you are a PhD or a postdoc or a PI, again, that there are differences in racial and ethnic groups with about a 50% Black-white gap in NIH funding that can be explained by the fact that you actually are not cited. And so, again, that continues to push downward actually on some of the measures that people have of the quality of your research. There also is a cumulative advantage. And so even when publishing the same number of papers, Black researchers are cited less frequently. And so they may not receive this. Maybe it's because they're not receiving the same advice from their mentors related to topic. That was something that was suggested by the NIH finding. And so if you maybe just something that's interesting or experimental, but it's not likely to actually be high yield in terms of findings, then it's not surprising then that you may find yourself with being less cited. And also the publication strategy, that if you're told that you need to go back to the laboratory and continue to do more and more experiments, as opposed to publishing early and often, this may actually also be part of it. But this disadvantage appears to accumulate because the Black-white publication gap widens as you actually go farther up in terms of your academic rank or your years as an investigator. Black researchers have fewer co-authors, and those fewer co-authors are not publishing in the highest quartile. And so Black publication records may be affected by pressure to instead provide other services to institutions. How many of us have heard that one before? The cultural taxation, where we're being asked to do clinical service in the case of medicine, mentor more students, or to somehow promote diversity without there being compensation, either in academic promotion or even in financial compensation for these things. What can we do about it? We can implement deliberate countermeasures. We can intentionally cite historically excluded groups. Often we have the opportunity to choose which article we want to reference as a review article, and so we can choose whose papers we decide. We can also highlight and expand programming that funds minoritized and excluded demographics. That certainly is being done at the NIH level, and that was one of the major findings that came from that initial paper, was clearly that the NIH, even internally, needed to actually examine its processes to begin looking at how it pushed funding to actually begin to deal with that disparity. We also need to reframe diversity and inclusion. I think many of us have seen this quote, that every system is perfectly designed to get the results that it gets. And so in many ways, it really fundamentally means that we need to change the system. That if we do not change the system to acknowledge the importance of diversity and inclusion, we will continue to see the disparities not only in academic work, but also in outcomes for patients. The current paradigm of science and education and publishing is owned and controlled by a majority. And so the opportunity for us to look at being on editorial boards, to be owners of publications, to examine how we go about who and how our work is represented will be important in terms of moving forward. We need to find ways to democratize it so that we are doing science for all. Right decisions require the right voices. And so in this instance, these are the people who are sitting in this room or my virtual room today, that without having people who remind perhaps the larger, are informing the larger dialogue about the things that are important and about how impactful we can be. We run the risk that decisions are being made because the right voices are not being represented. So why does DEI matter in academic settings? Diverse teams outperform homogeneous teams. And there have been many studies that have actually identified that. Diverse research teams result in higher manuscript citations, and they have a higher impact over homogeneous teams. In the healthcare settings with diverse faculty, data supports improved satisfaction for racial and ethnic minoritized patients. In healthcare settings with diverse faculty, patients report receiving higher quality care. And in academic environments with diverse faculty, BIPOC trainees report improved emotional and mental health outcomes. So my final thought is, in order for us to achieve health equity, we need leaders. And I believe that there are many leaders who are among those who are listening into this call, who care enough, know enough, and have the courage to do enough. Leaders who persevere until the job is done. And with that, I will stop. Thank you.
Thank you so much. Wow, what an excellent discussion on so many amazing topics, right? Taking us from the importance of history in the context of how these things are operating within the micro, the macro, and meso, or shall we say even global importance. I was just blown away with the graph of how this affects globally, because oftentimes we're so much embedded in our little village, right? We think of America, the United States, as being the world. Thank you so much. And also highlighting the recycling of racist rhetoric that we continue to see. I had no idea that some of the police detainees or police brutality was being rationalized or blamed on sickle cell disease. And I love your actionable recommendations. And I think you are truly an embodiment of the importance of having diversity in medicine and what happens when you do have those voices. So thank you so much, Dr. Thompson. I'm going to go ahead and open it up for questions, comments from those that are here.
Yeah, I can start. Dr. Thompson, thank you so much for this such powerful information. So I'm super glad that we are recording this session and we're able to send this out to our district campus community so they can view at their own pace. I really appreciate that. In terms of like our own individual community college setting, you mentioned implicit and explicit biases that do exist within the medical field. So when we have our community college professors and classified staff who at times encounter students, and if by any chance our students do happen to share that they are experiencing some of these symptoms with sickle cell, or they just flat out disclose that they have sickle cell, what are some best practices or some strategies that you can offer some of our employee group members on how to address that? Like, what do they do with this and like really important information?
Yeah, so thanks for bringing that one up. I think the most important thing is education and knowledge, and to really use it as the basis for it. I have many of my sickle cell patients who are doing well and are enrolled in college because they really have been again diagnosed by newborn screening, hopefully gotten evidence-based, high-quality care, and so really are looking toward the future. I think many of them, though, may have these unpredictable absences from class that may come from a pain episode or some other sickle cell complication. Some of those can be anticipated, and so certainly prior to college 504 plans, we recommend that all of our patients go to their schools really before the school year starts, so they have a 504 plan in place. So there's an understanding about what if any measures can be taken up by their school or school district, and of course it varies by school district what different schools have to offer. But we're putting that out there from the very beginning, not trying to say that this individual is not capable or that they're just this disability means that it's going to change their experience, but to know that the system actually can adapt if they need to. We also know that some of our sickle cell patients, though, will have had brain injuries from sickle cell disease during childhood. And so it's very important that many of them at some point during their primary and secondary education have an IEP put in place. Sometimes that follows them into college because many of them do need individual educational programs for them. Some of them will have deficits in things like executive function, where they need to actually go about doing some things in different ways. They may be able to do things, they may do very well on standardized tests as long as those tests are not timed. I think that most important is that we have, again, we work from this from a science basis, from a factual clinical basis, and move forward. These are not individuals that are asking for anything that they are not entitled to. There are aspects of sickle cell that do represent disabilities, and so being able to do this and to do this in a sensitive way. You know, I would consider this to be private health information, for instance. This is not information that I, in my opinion, that in the setting of an educational environment, it should be very similar to a medical environment, in that any of the conversations regarding someone's health status are done in private. And that this is not something to be disclosed inadvertently or otherwise to those who otherwise have no legitimate reason to know that.
Thank you so much.
Sorry, that's a little bit long, but it comes up all the time. But thank you for bringing it up, because I'm so excited when people with sickle cell really are out there living their best lives and doing the things that they really want to do.
Thank you, Dr. Letcher.
Again, thank you, Dr. Thompson, for your presentation. I have a comment and a question. And I know recently at Cypress College on our opening day, we had some presenters that talked about sustainable development goals. And I'm like, well, what is that? And I guess it was something that was, because we're talking about, you know, sometimes we think of, you know, healthcare or whatever as Dr. Cadena stated, as just American. We're just looking at that, but you brought out about the global instance of that. And in 2015, the United Nations, I guess they gathered for this summit for the purpose of looking at sustainable development goals. They developed 17 of those to end forms of inequities and poverty and so social justice. And one of those goals, number 3, was the good health and well-being. And so from what I can understand, that 198 governments kind of committed to these goals for their country. And so with that good health and well-being, looking at long-standing healthcare, looking at shortcomings and inequities in healthcare. And when you stated that, I'm like, yeah, sickle cell anemia would be one of those areas. And I was so enamored by that. I teach an English 103 and we're doing research where we have to take a position on an issue that has not been solved. And so I give the students, you know, some ideas, but I also included those 17 sustainable development goals. So they're not just looking at anything locally or nationally, but they're looking at issues that are global. And perhaps through their research paper, you know, they may come up with a viable solution. So education and knowledge is very important. And then also I had, this is kind of on a sadder note, I have a friend, a good friend for many years. Her son was diagnosed with sickle cell, and unfortunately he passed away at, he was 44 years old in 2022. And I know you mentioned about the mortality rate, but I can't remember exactly specifically. I guess my question is, those that pass away from sickle cell, is it complications due to the disease or the disease itself?
Well, obviously those are linked. And so, so the chronic injury to organs over time from the sickle cell disease is often the proximal cause of death. So you can have sickle heart disease, sickle lung disease that can cause failure of the heart or lungs. You can have chronic kidney disease that ultimately result in kidney failure, and sickle cell patients typically are not offered organ transplants, but certainly many of them would actually ultimately need kidney transplants. And you can have massive strokes, and so brain injuries, and some of those strokes are fatal. So those are the most common causes of death in patients with sickle cell disease. Hard to separate out sickle cell from what the proximal cause is, because one can make the argument that a 40-year-old would not otherwise have a stroke were it not for the fact that they have sickle cell.
Thank you.
Karen.
Yes, hi, Dr. Thompson. I just wanted to say that was an amazing, amazing talk. As an anthropologist, that you covered it so holistically and so detailed. I just, and the video that Leonore had shared with the voices of patients that she'd shared it last semester. I just wanted to share that it got me to redo a whole unit of applied anthropology in my physical anthropology class. And the voices of those individuals talking about how they had to dress up, or the one gentleman who talked about having to get, I think it was Duke University, the clothing from the college, not from like a Walmart or something, to show he actually had been there. I mean, it was heartbreaking. And so to take it from the individual at the micro level to the world level, where we looked at, I mean, when I did some research and I did that comparison in the United States of cystic fibrosis and sickle cell, and it was horrifying. The disparity in research and treatments. So not so much a question, but just accolades. And thank you so much for coming to our college and inspiring us to use this information. Thank you.
Well, of course, and I want to thank Dr. Cadena for the invitation. It was a very quick yes when the invitation came. So thank you.
Thank you. Virgil.
Yes, I want to also thank you as well for a wonderful presentation. I also want to state that I'm actually unfortunately appalled, and I hope that I'm not the only one that's upset and frustrated with the lack of progress as you've identified it. But you know, I'm 68 years old in 2 months, and so my whole lifetime I've heard of and been aware of sickle cell, not at the length that you've certainly detailed it, but I'm just angry with the lack of progress among academicians and also those in the professional ranks, as well as the socio-political aspect that you've outlined with bias, implicit and explicit types of stereotype as discrimination. So my question is, and I'm not going to put you on point for speaking for the entire physician profession of doctors, but how much longer before we see accelerated progress. I know you're at the forefront, but can we reduce, attenuate, or remove some of the racism and practical applications that are affecting lives to where we can see a significant difference in what we've been and what you've outlined as a historical past of just discriminatory practice among our professional ranks.
Well, so, and you're right, it'd be pretty tough to speak for the whole profession, wouldn't attend to. But I certainly typically consider myself to be one who's reasonably optimistic about most things. Kind of gets me through the day, if nothing else. But I think there are a couple of things that make me hopeful. One is I'm looking at who's sitting in the room now when I teach medical students. The medical student classrooms are far more diverse than they have ever been. And so my hope is that we are seeing a group of people who are more informed and who are more inclined inherently to actually advocate for themselves and their community, and who actually, again, will change the conversation. There are also a number of things that have happened recently in healthcare that I think are good things. So, for instance, it was not uncommon. So, when I showed you like that quote from 1910 in terms of the description of the person's race as if it were a part of their scientific background, that is now frowned upon, and in fact is eliminated for the most part in when you actually report out on a patient. So when you're making rounds or when you're describing a new patient, if you want to talk about their race is a social construct. It is actually not a biological feature. And so when you actually are framing who the patient is, you talk about the patient's age and their gender and why they're there. If there is a reason and you need to actually document their race or ethnicity, A is what the patient said they are, regardless of what you might surmise, what the patient says they are, and it's in their social history. And so it's actually acknowledging the fact that, that putting race in the first line, which certainly when I was in medical school, that it was understood. Mr. So-and-so is a 55-year-old Black man with blah, blah, blah. Was there any reason why I had to actually define that? Not necessarily, yet it was part of how we were educated. That has gone away. Another aspect of it is that there are several subspecialties, and mine is one of them, that are point by point examining instances within each of our subspecialties where we have inserted race or ethnicity into how we interpret lab tests, and then proposing that we actually use scientific evidence to actually take that apart. So that's going on in hematology, it's going on in nephrology, it's going on in cardiology, it's going on in multiple subspecialties where we are now going back in and really demanding of ourselves and sort of saying, why do we say that it's normal at this level if you're white, but it's abnormal if it's this level if you're Black? The consequences of that, for instance, one of them is kidney disease, for instance. That was probably the one that has been the most important, because that distinction in how well your kidneys work was often the difference between you're being offered a new chemotherapy drug if you have cancer, or you're being offered dialysis if you have kidney disease, because we were using a test and we had two different standards based on race. We now know that those really should be abandoned. And so there are areas when each specialty is going in. It will take a lot because they are pervasive. And so it's going to have to be beyond academic medical centers. But if we can point by point, really among ourselves, charge ourselves, we'll sort of say, why do we still do it that way? Well, maybe we should stop doing it that way because there really is not a scientific reason to continue doing it, and it is causing harm. So I do think that there are instances. I think we are a long way from eliminating all health disparities. But these are just examples of things that I at least am seeing that give me hope that there are at least a subset of people who are willing to do the work to try to move in that direction.
Thank you so very much. I appreciate that.
Anybody else would like to make any questions, comments?
Just a comment.
I want to hear your comment, but I'm going to be so disappointed if none of your students unmic themselves because I know mine don't do it either, but really.
I'm a student.
Okay, good. But wait, we have to go next.
I'm so sorry. I'm a student.
Okay.
Go ahead.
Go ahead,
Is
Aaliyah.
the student going?
Aaliyah?
I just wanted to say thank you because yeah, hi. I'm one of Dr. Letcher's students in her English 104 course. And I just want to say thank you for just I knew nothing about sickle cell literally coming into this. So you really educated me on something. And I was actually on a phone call with my best friend who's studying to be a nurse. And so I had to let her know like I gotta get off the phone so I could really concentrate because I knew nothing about sickle cell. She was telling me a little bit, my best friend. So I was like, let me hang up with you and tune in because I really got educated on a lot. And it's pretty sad when you spoke about like the kids that go through this. So, and I'm a mom myself, and to think that, my son could have possibly even got that, like it's pretty scary. So thank you for just educating me and opening up my, horizons to this. So thank you for that. I wanted to say that.
Thank you.
I wanted to talk to, hello?
Yeah, go ahead, Adriana.
Thank you so much, Dr. Thompson. That was an amazing presentation. Some of my interest in grad school was with diabetes and kind of the racialization of diabetes. And so I was super interested in hearing about all of this. And it's really good to hear that the medical field is taking these steps to kind of veer away from using race as a determinant. But I wanted to kind of get your opinion or your experience of how common is it to actually hear some of your colleagues still, reference or, these lingering kind of scientific racist assumptions. I mean, I don't know if because like you were referencing how the ER treatment, how there's different, treatment for different, children of different races. I mean, those practitioners exist somewhere, is that just more on the practitioner level or the medical research level? Like just a little bit of maybe anecdotal experience with that.
Yeah, thank you for your comments. I can't say I see it every day. I see it often. And a lot of it is I believe that most of it is implicit. I believe that most of my colleagues really see themselves as champions for children. I honestly believe that they come to work every day believing that I care about kids. Yet they treat certain children differently. And many of them are okay if it's pointed out to them. And so when I say recognize it, name it, check your bias and check others' bias, some of them can actually hear you. So like, for instance, one example in my field is some of my patients are patients who are much sicker with sickle cell than others. And they require a lot more care. So let's just say, and Dr. Cadena knows, we both love to travel. And I'd say at this point in time, we're both stocking away lots of miles in our bank because we are frequent flyers. And that means we board planes and we travel around the world. Well, a patient being called a frequent flyer is actually a negative term. And so when someone calls someone a frequent flyer, I stop them even before they have to tell me what else they have to say. Because it's just like, not information, not useful, clearly it reflects your bias. This is someone who has a high acute care utilization. Let's frame it that way, because then that does give me information without necessarily naming or labeling a patient. And so calling them frequent flyers, if it's not me and my account on United Airlines, then you kind of need to stop doing that one. Or having sickle cell patients called sicklers. Well, I don't think I call brain tumor patients, oh, that brain tumor over there. I think I call them by their name. And as would be expected, that we are not defined by our disease. And so again, I think a nurse not being well-intended sort of saying, I have this sickler down the hall, can I ask about them? It's like, well, I don't know what you're talking about, but are you talking about Mr. So-and-so in this room? Because really, but please don't use that term. That term by the patients themselves is considered to be derogatory. And again, the nurse was like, I wasn't aware. I thought I heard someone else use that term, so that was how I was taught, that you just call sickle cell patients sicklers for short. Well, if you ask patients, the patients just chafe at being, again, referred to by the biology of their red cells, not by them as whole human beings. So things like that, you just, and again, this otherwise is someone who I think is a incredibly compassionate provider, just needs to be educated and sometimes reminded. But I think that there are lots of examples of things like that slip in and out of our lives. And I think as long as we can have a conversation without being confrontational or without shutting down dialogue, because again, I'm an educator just like you all are. My goal is not to shut people down. My goal is to actually get people to keep talking. And so I can't do that if in fact I've somehow put you in a box. But I want you to move forward being educated is really what I want you to do.
Thank you so much. Yeah, that's a good point, because sometimes people are just, talking casually and they don't really realize the implications of that. Yeah, I mean, kind of catapulted my interest with my subject with diabetes is when I got gestational diabetes. My doctor, I was like ready to cry, and my doctor's like, "Don't worry, all Latinas get it." So I was like, "What?" So that being an anthropologist, it just catapulted me into this whole, idea. How could a practitioner tell me that? How could she assume my ethnicity? Is there a racial purity? All these ideas. So listening to your talk was just really was amazing. And to have your background and your experience, you're in there, in the trenches, so to speak. So it was really captivating. Thank you. Thank you so much.
Thank you. Your lived experience, so don't underestimate that, because I think that actually drives many of us. And so don't underestimate the contributions of your own lived experience to what you're doing every day.
Well, thank you. Thank you again.
And Dr. Cadena, I think I cut off Sergio. I don't know if he's still on, but
Yes,
your
he's right here.
I'm still here, but I wanted to make sure that, students or anybody else that has a specific question can take advantage of, the generosity of having you here. So I really don't have a question. I just really quickly will say that I'm just echoing what everybody else already said. This was a great presentation. And just like Aaliyah mentioned, I personally, I didn't know I would say almost nothing about sickle cell. And I mean, this is just information ammunition that is going to help me personally tremendously, especially in the classroom. But one really interesting thing that you brought up that really connects to a lot of things, and in fact, I was talking about this in class on Wednesday, is that idea about the labels and how when we are talking or people are talking, because I had a student say something, and many times during casual conversation, we will either qualify or preface, oh, my Black friend, my Asian friend, or, this person, and they will actually, and what's the point? And I think that the implications, obviously, in the medical field are huge. But again, we go back to this implicit component associated with bias. And I am sure that if I do an analysis of my own, conversations and just like everybody else, I'm sure there are things that I need to eliminate, I need to change, I need to alter. So thank you so much for bringing light to that and for your presentation. Thank you.
I
Ashley?
actually had one more. I'm sorry.
Can you hold on? I think Ashley
yes.
has a hand up, and then we'll come back. Can you hold on to that thought, Adriana?
Okay, thank you.
Well, hello everyone. I don't know where to start, but thank you, Dr. Thompson, for the presentation. I was really happy to see that there was because yesterday I saw this in the calendar, on the events calendar, and I was really happy to see that this discussion was going to be discussed. And so because I have sickle cell myself, and it's not really a topic of discussion most of the time outside of the hospital realm. And yeah, so I was really eager to be a part of this. But my question to you is, what would you tell I guess a newly adult patient coming from pediatrics? Because when it comes to sickle cell, we are in pediatrics our entire lives, and then when we turn 21, we have to transfer out to adult care. So what would you tell a newly adult patient?
So great question. And really, boy, that could be a whole nother talk in and of itself. But transitions from pediatric to adult care for people who have chronic illnesses, and certainly those who have inherited conditions, many of the problems are not specific to sickle cell disease, but clearly we need to do better. There needs to be greater preparation for people to have the life skills to be able to be independent and advocate for themselves. But a lot of the issues really come down to the system. And so really being able to ensure that they have adequate healthcare coverage and that they have all the other things that they're going to need to be successful adults. We don't have those things carved out nearly as well as we need to. I'm part of a number of different efforts that are looking at transitions of care across pediatrics, but also specifically in blood disorders, because it's a complex time. Many people, not only are they trying to be more independent, and their parents are giving them independence, which they should as adults, yet the kind of decision making that they have to do sometimes is extraordinary. They may be losing not only their provider, they may also be losing their usual source of healthcare insurance. So there's a lot of things that are going on all at one time. And then in many conditions, sickle cell included, these additional stressors, the delays in care, the lack of compliance with things that your mother might have taken care of you before, only contributed to that disease getting worse just when you're trying to take care of yourself. So it's a complicated question, and I would say that there's not one answer, but you are absolutely right. Some of that high mortality, that uptick in mortality that I talked about during that time has to do with transitions from pediatric to adult care, and we need to be able to do it better. So I don't have a single answer, but yes, that is an area that we must continue to work on.
Thank you. Thank you, Ashley, for your comments. Adriana, did you want to say something? Sorry to cut you off.
Sure. Good luck, Ashley, to that transition, and wishing you well. But I wanted to ask quickly, Dr. Thompson, you had referenced when Virgil had mentioned when you were talking about his giving him his answer, you had mentioned that when they referenced race for certain levels, I guess that like affected if people were receiving treatment or what I'm not sure exactly. I think it was like liver.
Yeah, so it's remarkable how many times, no matter what the scenario is. So for instance, that early on, I quoted a paper that was not about sickle cell, but it was looking at from 2016, giving people scenarios, in circumstances where race is part of the scenario, yet the Black patients were given less. So this is not, that's not unique. That was probably one of the more stark ones. Yet I don't, I'm not saying that I know nothing about any of these individuals. Can I say that they're necessarily racist? No. Can we appreciate though that their bias could cause harm? That is, I think, the most important part of that conversation. So it's not just sickle cell; it really is pervasive. And I dare say that if I would encourage you to actually talk to somebody, say, who is in the criminal justice system or in finance or in any of those other areas where structural racism and structural inequities, systemic inequities can be found. I guarantee you, whether it's housing, whether it is banking, whether it is any of those, that one could come up with a similar scenario, that there are instances when you insert race, you treat people differently. And the question is that acceptable? So I don't know that there is a solution that is universal across all of these. Again, it's not about intent, but it is about consequences. And so being able to examine the consequences of that. And, certainly even when we talk casually, many of us, many people of color, myself included, are very proud of being people of color. I'm not interested in being erased. Yeah. So don't get me wrong on this one. So that's what I'm interested in. But and understand that my American experience is informed by my race. So I think kind of, on the one hand, that's not what's being asked, is for us to be colorblind, because by colorblind, in some ways, by saying that, it means you want to erase part of something that is inherently part of me, I might value. So I think we have to, it's not a one size fits all, but I do think that in an education environment, we need to examine when is that something that is helpful? And when is it not helpful?
That's what I was kind of thinking, like, how do we don't want to eliminate the idea of, health disparities. It's a reality, but how, like, it's such like a tricky thing where you're documenting that different people in different groups are unhealthy, but it's like a hard way. I could see as a practitioner, it's really hard, because how do you not document people's race, but at the same time document that this population has this illness more than another group? It's like.
Yeah.
I agree.
And I know we want to be mindful of and respectful of your time. Francisco had his hand up. Do you have time for one last question, or do you have to? Okay. Thank you. Francisco.
Yes, good morning. Thank you, Dr. Thompson, for such a great informative information given us today. I teach medical microbiology. I'm a biology instructor at Cypress College, and I cover infectious diseases, and I know sickle cell disease is not necessarily an infectious disease, but it's analogous, obviously. And I wanted to just get straight to my question. I do have a little bit of experience with medical curriculum. I used to, some people here know, I'll share something very personal. I used to be a medical student. I didn't finish my program, and it was actually in your neck of the woods. I lived in Philadelphia for a couple of years. And so I'm familiar a little bit with the medical curriculum. You mentioned that today's medical student class is probably one of the most diverse. Certainly when I was a medical student several years ago, it was fairly diverse as well. And my question to you was, what can we do at the medical school curriculum to close some of these gaps? Because you're saying, right now it's very diverse, but what about the curriculum? I feel like you can have the most diverse class, but what about what we're teaching our students today, our future doctors?
Well, I think that's fair, because after all, who's teaching them? Well, I am at Children's Hospital Philadelphia. It has the #1 Department of Pediatrics in the United States. I am the only, until October, I was the only person of color who was a division chief. We're the next rung down from department chairman. And again, and is it because there are not other, it is so complex in terms of exactly, you may very well not see a person of color in many of our Zoom experiences. And I dare say, when I'm teaching medical students, there are times when I appreciate that most people who are standing in front of them are still don't necessarily reflect that diversity. I think it's a matter of listening to the students, because a lot of the students want a more diverse, a more inclusive experience. Many of them want to know how to manage anyone who walks in the door, and you can't do that if you haven't been taught. Like, for instance, another example is my transgender patients. We struggle with language. We struggle with, are we teaching students the right way, and are we doing the right thing for the patients? We're learning as we go on that one. Yet many of us feel heavily, are seriously, we know that in order to sort of to be as effective as we can in terms of taking care of our patients, and to be educators, that we're having to re-educate ourselves in terms of how do we actually walk through you know, whether it's pronouns or whether it is, you know, whether it is race. I mean, whatever it is, I call the patient whatever the patient wants to be called. There are times when I may, you know, that we have to be open to being checked. You know, there are times when a student may present an alternate point of view based on their lived experience, and many of us are accustomed to having patients who do that, and so a student who does that is fine. We want all students to actually make choices that work for them, and I don't want them to feel like, well, because you're from an underrepresented community, you must therefore only go back to your community, and that is the only contribution you can make. If that's what drives you, do not let anything stop you. If on the other hand, you decide I want to be a microbiologist and I want to be a PhD and work in a laboratory, even though I'm going to be the only person of color in this laboratory, there needs to be places where you are celebrated, where you are supported. And trying to make sure that we're hearing students about what individually they want to do and being able to support them. I'm worried about, for instance, right now, the amount of debt that students are coming out of medical school with right now. And some of their debt is probably going to invariably impact their choices. I don't know, you can be a primary care doctor in a community practice working in a public health clinic if you owe $200,000-300,000 in student debt. It's just not possible. And so how do we go about ensuring that they can make the choices that matter to them, and not compromise because of finances? I mean, I think that these are, many of us have continued to talk about those things, like how do we make medical education, not only the content, but also the cost, ones that really don't disenfranchise students. And so I don't know that it's one answer. I think that you're bringing it up, though, and continuing to bring it up is the only way we're going to actually make progress. And I think we can't pretend that that just because the room looks different does not mean that we have overcome all the things that have gotten us to where we are.
Thank you.
Good and bad. Yeah, sure.
Thank you again for being here. It's been such a pleasure to share this information and to learn so much. And again, we really appreciate you taking the time. We know you're really busy, and we truly appreciate you.
My pleasure. It's really been quite a treat for me. It's also been nice to see the few of you who are in places where I can see outside. And of course, you may or may know, I'm a California native, and so I truly miss miss my family. Yes. Miss the environment there too. So, but thank you so much for the invitation. It's really been terrific.
We miss you too. Take care. Thank you everyone for being here. Have a wonderful rest of your day. Bye-bye.
Thank you.
Bye-bye.